certified in anesthesiology, pain management, and addiction medicine. He has been the past president for CalSIPP in 2015 to 2017, and currently he serves on the board of directors for CalSIPP. He lives and practices interventional pain management and addiction medicine in Camarillo, California, but with a heavy emphasis on the psychosocial and spiritual aspects of pain experience. He has a unique perspective as a pain and addiction relief expert and considerable experience using the buprenorphine for chronic pain as well as addiction. Please join me in welcoming Dr. Joseph Cabre for our seminar on buprenorphine for chronic pain, transforming our most challenging patients, our greatest success stories. Welcome, Joe. Over to you.
Thank you for that introduction, Ripu, and welcome everyone to our talk today. The title is Buprenorphine for Chronic Pain, Transforming Our Most Challenging Patients into Our Greatest Success Stories. I think most of us, all of us, certainly by now are familiar with buprenorphine as a drug that's used in opioid use disorder treatment. And perhaps we're less familiar with what a wonderful drug buprenorphine is for chronic pain. And hopefully after this talk, we'll all be, utilizing, taking advantage of this fantastic weapon in our arsenal in treating chronic pain. So I really don't have anything to disclose related to this talk. I have my own pain practice in Camarillo. I'm triple board certified anesthesia, pain, and addiction medicine, past president of CalSIPP, current director. I'm an instructor for ACIP, and I have my own pain management support group in Camarillo. And I wrote I co-wrote a couple of the chapters of the ACIP textbook on regenerative medicine. So this talk is about chronic pain. It's about buprenorphine for chronic pain. You're going to hear me re-emphasizing that over and over again, because I think we really need to start thinking of this drug in this way. Chronic pain is pain lasting than 3 months, right? We all know these things. It's more prevalent than heart disease, diabetes, and cancer combined. It's increased substantially over the last 20 years. 1 in 5 adults are affected. 1 out of 10 adults have high impact chronic pain, which significantly limits activities. And, chronic pain can lead to a whole host of coexisting disorders, including depression, anxiety, insomnia, fatigue, reduced quality of life and function, even employment restrictions. And the Pain Management Best Practices Interagency Task Force described the current state of chronic pain care as a crisis with profound societal costs. And, we have to talk about non-opioid medications. They are not risk-free either. All medications, not just opioids, need to be selected based on diagnosis, pain mechanisms, and comorbidities after thorough history and physical diagnostic testing and, a risk-benefit analysis. And we know that these non-opioid drugs carry significant risks. NSAIDs have GI, hypertension, cardiovascular, and kidney risks. There's liver risks with Tylenol, and there are fall risks and sedation risks with a lot of the other drugs we use. Looking at conventional opioids, there is really zero evidence for long-term efficacy. I think in large part due to tolerance and dependence, which, is often referred to as opioid-induced hyperalgesia. And yet these drugs with no long-term efficacy evidence have a host of potential risks that are well known. There are hundreds of studies in the worldwide literature showing how opioids, especially high-dose opioid regimens, are very risky and not efficacious long-term. So the unwanted effects are due to the mechanism of action, full activation of the mu receptors in the central nervous system. Full mu activation leads to opioid-induced hyperalgesia. Full mu activation contributes to the side effects, and including sedation, respiratory depression, constipation, nausea, vomiting, immunosuppression, irritability, anxiety, insomnia, and pruritus. Full mu activation also triggers the reward pathways, leading to risk of opioid use disorder and its sequelae, everything from misuse to overdose death. And for this reason, opioids are not considered a first-line drug for pain. But remember, opioid use disorder and overdose deaths are really just the tip of the unwanted iceberg, right? There are many long-term prescription opioid users that are using the medications as prescribed by their physician for chronic pain who don't have addiction, who are nonetheless suffering with loss of efficacy, opioid-induced hyperalgesia, and side effects needlessly. I hope this talk will make that clear. These are patients that we would consider good patients, right? No aberrant behaviors, urine screens, cures reports are all good, but doesn't mean these patients are doing well. And we'll talk more about that as we go forward. Buprenorphine is different. Buprenorphine is underutilized and overlooked for chronic pain. It's derived from the poppy opium alkaloid thebaine. It's a mixed action agonist antagonist at 4 different opioid receptors. And I'm going to go into detail about that over the next few minutes. It is a DEA Schedule III drug, so there is less misuse potential. You can phone this drug in. You can put refills on this drug. It's much easier to prescribe. Unique pharmacodynamics induce potent analgesia with fewer side effects than conventional opioids. And I really want to emphasize that potent analgesia, because that is one of the misconceptions about buprenorphine, is that because it's a partial agonist, it's not a potent analgesic. And I hope to dispel that, nasty rumor during this talk. It has this unique ceiling effect for respiratory depression, but not for analgesia. And we'll see why in just a minute. So this is a chart showing the ceiling effect for respiratory depression with buprenorphine. You can see the orange line as the dose goes up on the x-axis, the opioid effect goes up on the y-axis, and you quickly go from analgesia to respiratory depression. With buprenorphine, which is that bluer line, you see that after achieving analgesia, the curve kind of flattens out. And so you have much more forgiveness as the dose goes up before you achieve respiratory depression. And this is perhaps one of the most important things to know about buprenorphine, its safety profile. But it's also important to know about its tolerability profile and its efficacy. That's the other thing that I think has to be made clear to the community. And we are all educators in our own communities. We're the pain experts. We should be able to tell people about this. So here are the 4 different receptors where we know that buprenorphine has activity. At the mu receptor, it's a partial agonist. At the delta receptor, it's an antagonist. At the kappa receptor, it's also an antagonist. And at the ORL1, or opioid receptor-like 1 receptor, kind of an awkward name, it's an agonist. And so let's look at each one of these separately. At the mu receptor, it's a partial mu agonist. This is a very important slide for everybody here to pay close attention to. Conventional opioid binding to the mu receptor activates 2 intracellular downstream signaling pathways. I will bet that most of us are not aware of this. And so the 2 proteins are the 2 pathways are the G protein pathway, which provides analgesia, the good that we want from the opioids. And there's this other beta-arrestin pathway that gets activated. And that's what causes the side effects and the inhibition of analgesia, or opioid-induced hyperalgesia. And so this is important to know, because this is really, I think, one of the key factors why buprenorphine is such a wonderful drug for chronic pain. Because buprenorphine preferentially activates that G protein pathway over the beta-arrestin pathway. This is what we mean by partial agonism, not that it's less efficacious for pain, but that it only activates the good things about the mu receptor. So this leads to greater efficacy and more favorable tolerability and side effect profile, not inferior analgesia. So please pay close attention to this. If you have any questions about this, put them in the chat room. We can talk about it later. This is key. Buprenorphine also facilitates migration of mu receptors to cell membranes, which also contributes to enhanced analgesia. Buprenorphine also dissociates more slowly from the mu receptors, resulting in prolonged analgesia and less end-of-dose withdrawal pain. Okay? It's got a high affinity and tight binding to the mu receptors, and this blocks cravings and withdrawals and provides competitive inhibition against full or pure mu agonists. And this prohibits their euphoric effects and is the basis for the use of buprenorphine in opioid use disorder. But remember, we're not talking about opioid use disorder today. We're talking about buprenorphine for chronic pain, okay? And there's more about the mu agonism. There's this tissue specificity. So buprenorphine preferentially activates spinal versus supraspinal mu receptors. And this provides analgesia while also limiting euphoria and respiratory depression. So I like to think of it as a little bit like a sublingual intrathecal pump. And I think anybody who you're considering for pump implant who's on opioids should probably, try an Suboxone induction first or buprenorphine induction first, because they might just get a great result without the need for an implantable device. At delta and kappa receptors, buprenorphine is an antagonist, and this results in less respiratory depression, sedation, dysphoria, constipation, immunosuppression, tolerance, and this opioid-induced hyperalgesia, which I just call dependence and tolerance, right? This delta and kappa antagonism can also potentiate the antidepressant, anxiolytic, and antihostility effects that we see, along with reduced suicidal tendencies that we see with patients when they get on buprenorphine. At the ORL1 receptor, buprenorphine is an agonist, and this blocks the reward system and slows tolerance, so you get better long-term efficacy and lower potential for misuse. It also, activation of this receptor in the spinal cord may also contribute to its analgesic effects. There are other advantages with buprenorphine. It has a very rapid onset when taken sublingually. We're talking 5 or 10 or 15 minutes as opposed to 45 to 60 minutes with an oral pill that you swallow. It's also got less immunosuppression and less constipation. It doesn't even seem to cause sphincter of Oddi spasm. And those of us who are anesthesiologists, remember, in the OR when you're doing a procedure on the gallbladder, you want to sort of avoid opioids to prevent this sphincter spasm. And that sort of, I think, is, signaling that the whole gut sphincters are not as affected by buprenorphine as they are by conventional opioids. But there's also more uniform blood levels when we're using buprenorphine. It's a smoother ride, and we think that that might also be advantageous in avoiding opioid-induced constipation. There are a lot of misconceptions about buprenorphine in America, and I want to try and dispel some of them today. I'm going to spend a little bit of time talking about these. And I already said a little bit about this partial agonism, this G protein pathway preference. And this has been misconstrued as partial analgesic efficacy. And I think it's a sin, it's a shame, because we've got that holy grail that we've been looking for all along, right? If only we had a drug that could do what a full agonist like oxycodone or fentanyl can do without all the baggage. And, I would argue that drug is here. We have a drug that preferentially does the good stuff, and we're not using it. So I hope to get the word out to everybody, and that's what we're doing here today. So, it's misconstrued as a partial agonist, meaning partial analgesic efficacy. But in clinical studies for various conditions, including acute pain, like surgical pain and renal colic, cancer pain, non-cancer pain, it doesn't really matter. Buprenorphine has demonstrated superior or equal efficacy in terms of analgesia and hyperalgesia when compared to morphine, oxycodone, fentanyl, sufentanil, and other full or pure mu agonists. In fact, buprenorphine is 25 to 100 times more potent than morphine for pain. And, think about it. We're using 2 milligrams, sometimes 1 milligram, up to 24 milligrams a day for pain. And, with morphine, we're oftentimes using hundreds, if not thousands of milligrams, in the old days to treat pain. So this really is a very powerful pain medication. I tell my patients that, and, they come back and agree it is. Other misconceptions about this drug, it's better known in the US for opioid use disorder, right? So everybody associates buprenorphine with opioid use disorder, but it was actually developed and used as an analgesic for severe pain in Europe for over 3 decades before it ever got approval in the United States for opioid use disorder. It was approved for opioid use disorder in the United States in 2002. And, that's all we know about it, basically. That's all most people know about it in this country. But it really was used intravenously and sublingually for many years in Europe as an analgesic for severe pain. And so it's important to remember this. Today's talk is about buprenorphine for chronic pain. And so I want that to be perfectly clear to us, to our patients, to the community. Also, remember that task force I talked about that said that we're in a pain crisis, an expensive, costly crisis? Well, that same task force advocated for buprenorphine as primary therapy before failing conventional opioids. And because it has superior efficacy, greater tolerability, and lower risk for misuse and respiratory depression. Formulations. Let's talk a little bit about how buprenorphine comes. Due to pre-systemic metabolism in the GI tract and first-pass metabolism in the liver, its bioavailability orally is only 15%. But that's okay, because due to high lipophilicity and low molecular weight, it has high transdermal and transmucosal bioavailability. So guess what? The formulations are transdermal and transmucosal. And there are many advantages to that. It's better than an oral medication. And I tell my patients that, and they agree. It's advantageous that we're not taking this medication by mouth. The transdermal patch is the buprenorphine patch. The brand name is Butrans, but it comes generically now. It comes from 5 to 20 micrograms per hour, and it's suitable for less than 80 morphine milliequivalents per day. Patients who are at that, 80 or less. And it is FDA indicated for chronic severe pain, not for addiction. We also have this buccal formulation called Belbuca There is no generic for this. It's suitable for patients taking up to 160 morphine milliequivalents, and it is FDA indicated for chronic severe pain, not for addiction. And then we have the drug that we're all more familiar with, the buprenorphine sublingual, known as Subutex, Suboxone, Subzolve, and those are some name brands. And this is suitable really for any morphine equivalent off-label for pain. It is FDA indicated for opioid use disorder, and you need a special DEA X license or Data 2000 waiver from SAMHSA in order to prescribe buprenorphine for opioid use disorder. Now, we use drugs off-label all the time. Gabapentin is only indicated for postherpetic neuralgia. It has no other FDA indication, but we use it for sleep, we use it for radiculopathy, we use it for all kinds of neuropathic pain anyway. And so I use Suboxone probably more than any other formulation in my practice for chronic pain, okay? And it just gives me a lot more flexibility. I'm able to, have the patient find their dose much easier when they're on a drug that they, a patch or a pill that they, a film or a pill that they can cut and take multiple times per day until they really find, their dose, because it can be a little bit unpredictable. And, when you're using the transdermal patch, if you slap a 10 microgram patch on and it's too strong or too weak, you basically got to wait a month before you can switch it. Or, you can move faster, but then they got all these extra patches laying around. Same thing with the Belbuca film. Once you order, it's twice a day. And once you put that, in there, if let's say you order a 150 microgram patch twice a day, it might be too strong or too weak, and they don't have a lot of options after that. So sublingual buprenorphine is, for me, the easiest way to start people on Suboxone, on buprenorphine for chronic pain, right? We're still talking about chronic pain. I also treat addiction with buprenorphine, and, it's very similar, treating addiction or treating chronic pain. So let's kind of recap where we are so far. And I want to see, I want to see all these things that I've pointed out right on, a couple of pages here to realize how advantageous this medication is. It has these unique mechanisms of action, right? Not just one. And this has specific advantages. It has less respiratory depression, so less risk of OD death. It has superior efficacy, better pain relief. It has more rapid onset when taken sublingually. It has a long half-life and clinical effects, so less withdrawal and perhaps better sleep. And that's one of the things we see right away. You'll notice your patients will tell you immediately that they're sleeping better. And maybe that's why they look so much better too, but it may be due to this long half-life where they sleep through the night. They don't wake up in withdrawals. They wake up feeling very comfortable and relaxed. There's also less tolerance and hyperalgesia, so greater long-term efficacy. There's less euphoria and abuse potential. Works great for patients with coexisting opioid use disorder. I think it's funny how a lot of docs, have come to me over the years and asked me, how do you know if they have use disorder or pain? Is the pain real? I tell people I really don't need to know the answer to that question in order to treat them, because the treatment's the same. Let's face it, just about everybody who's on chronic daily opioids has 2 out of the 11 criteria a DSM-5 criteria for an opioid use disorder. So they have a mild use disorder. Basically, anybody who's using daily opioids qualifies as having a mild use disorder. If they have, dependence and tolerance, that's mild use disorder. So this is a great drug for people who have both. And we tend to have this idea, that, either they're in pain or they have an opioid use disorder. And it's kind of like saying, you can't have high blood pressure and diabetes at the same time. It's one or the other. It is very possible, and I think quite common for patients we see in our practices to have real, bona fide, sincere pain that they're suffering with and need help with, and an opioid use disorder at the same time. And that's a complex pain patient. And, Suboxone comes to the rescue. Buprenorphine to the rescue. So let's look at more of these advantages. There are less side effects, greater tolerability. It's a Schedule 3. So, and generics are available. So it's easy to prescribe, easier to get for your patients. I really never have any trouble getting any of these drugs for any of my patients. It comes in these transdermal, buccal, and sublingual formulations, which avoid the GI tract. And that can be a real plus. And we'll talk a little bit more about that in some future slides. It has this tissue specificity for the spinal cord, right? I like to refer to it as a sublingual intrathecal pump. It looks and acts a lot like a pump. Patients are, not feeling high. They're not feeling sedated. They're not in withdrawals. Their pain is managed, and they feel normal, kind of like what a pump is supposed to accomplish, right? Greater efficacy with less side effects. It has this antidepressant or anxiolytic effect. They're even experimenting with this drug in the psychiatric literature for patients who have, recalcitrant depression. And so this is perhaps why we see the mood improve so much when people convert to buprenorphine, and why maybe also why they're getting better sleep. And sleep is everything, and especially to pain patients. And that's one of the most dramatic things I see is patients really start talking about their pain improving. So, so far, if you're with me so far, this is kind of a no-brainer. On paper, this drug is, a real winner. And why wouldn't we use this on everybody? But I want to go even further. Wait, there's more. And I want to talk about specific populations and, specifically patients with cancer pain, patients with neuropathic pain, older adults, and patients with impaired renal function. So a third of cancer pain patients have moderate to severe pain. And, randomized trials have demonstrated efficacy of buprenorphine in cancer pain. There is one multi-center RCT which showed buprenorphine as effective as Schedule 2 medications for cancer pain. I think this might be surprising to a lot of you. I hope it is. It really was to me even. And I've got a lot of experience with this drug for chronic pain. Systematic review showed efficacy comparable to fentanyl, but lower risks for tolerance and better tolerability. So this is a great drug for a cancer patient. I think oftentimes cancer patients, just like non-cancer patients, if they're started on opioids too soon and escalated too rapidly, when they really need that pain relief at the end, they're already tolerant and they're already, they're not going to be able to get the relief they need from the opioids. Wouldn't it be much better to start them on something like this and have it work all the way through to end of life? Remember that we have transdermal, sublingual, and buccal formulations. So these are especially useful in cancer patients who perhaps can't swallow or have chemotherapy-related nausea vomiting. This is a drug that would work for them anyway. In neuropathic pain, traditional opioids really don't work that well. We know that. We use them anyway. But for central and neuropathic pain, they can really be kind of counterproductive, actually. And buprenorphine does dampen central sensitization and may have distinct advantages for neuropathic pain. And so we have to, remember that this is another advantage in using buprenorphine. Most of our patients have at least some neuropathic pain, in their story. And so this is a big plus. In fact, the consensus panel on opioids and chronic pain concluded that buprenorphine shows a distinct benefit in improving neuropathic pain. There's no other pure mu agonist that can claim that. On older adults, pain gets more common, right? And treatment options really kind of get more difficult because of their age, because of their greater polypharmacy, their comorbidities, their metabolism slows, their PK and pharmacodynamics change. And so it gets more challenging in older adults to manage their pain. But buprenorphine is highly globulin bound, so it has less risk for drug-drug interactions, right? These patients are on a lot of drugs. It also shows similar efficacy in the over 65 age group. And while conventional opioids had a greater risk for fracture, buprenorphine didn't. And the authors of the paper thought that this was likely due to less dizziness with buprenorphine. A retrospective analysis also showed similar adverse effects in the under 65 and older 65 age group. So similar efficacy and similar safety in older adults. Important. Impaired renal function. Conventional opioids have a risk of a toxicity due to accumulation of active metabolites, right? Well, buprenorphine is primarily eliminated in the liver. And so plasma concentrations are comparable regardless of renal function. And buprenorphine can be used safely even in dialysis-dependent patients. Okay, so are you still with me? We had all these advantages that I listed earlier, and we won't go through them all again, but I mean, look at that. That is a big list of advantages. On paper, this is a no-brainer. But there's more. It's great for cancer pain, great for neuropathic pain, great for older adults due to low drug interactions and similar efficacy safety. It's safe for renal impairment, including dialysis. There's less fracture risk, probably due to less dizziness, and it's not an immunosuppressive drug. Right? I mean, I hope you're all agreeing that this is kind of almost too good to be true. But I'll tell you something. As good as all this sounds on paper, this is exactly what I've experienced in my practice over the last, 10 plus years. And a picture does paint 1,000 words. These are some pictures that I just got off the internet of people before and after recovery from drug addiction. And, these are addicts, right? These are patients who are using recreationally for euphoric effects. But really, in my practice, I meet a lot of pain patients who are good patients who are taking their medications as prescribed by their physicians with no aberrant behaviors, and they still kind of look like that before picture. A lot of them look kind of strung out, exhausted, just really tired. And, it's a tough thing to live with that chronic subacute withdrawal that these patients are living with. And their pain is poorly managed, many of them, most of them in my practice. And it's not working well. And if we, if we did an epidural and a patient said, I'm not getting any relief, we wouldn't keep doing epidurals every day. But that's what we do with these opioids. And so I want to tell you that this still amazes me in my practice. To this day, every time a patient comes back after a Suboxone induction, and I do multiple of these per week, I'm always still amazed. It is incredibly rewarding to see that face change. And it's not just their face, yes, their eyes soften, their smiles brighten, their skin looks better, they're dressed better, they laugh differently, they smile differently, they move differently. Sometimes I barely recognize these patients, and I say, "What happened to you?" And they say, "That's what all my friends and family are saying too. I'm sleeping better, I'm feeling better, my mood is improved, and my pain is gone, or it's much better, or worst case scenario, my pain's the same, but everything else is better." And they look 15 years younger. I mean, this has been my pretty much, on every patient I've done this with. I mean, I had, some failures, but even those I think really were, could have been salvaged, maybe still can be salvaged. So I really want to point out how everything that I've talked about in this talk isn't just like theoretical and, from the studies. This is everything that I've talked about I see in my everyday practice. And it amazes me every time. And I just want to, encourage everybody to start getting familiar with this drug. I'll give you my cell phone and email address at the end, and I love talking about this stuff. You can always ask me if you have any questions. But there are some barriers to entry with this drug, right? It can be a difficult sell. And so I think that motivational interviewing is a skill that every pain physician should have. And if you don't know what it is, I encourage you to go look it up and, take some courses. It's about how to help people, make positive changes. And you have to make it their idea to change. So, if you say you better change, it's not as effective as, creating ambivalence, leading them to make that decision themselves. And that's what motivational interviewing is all about. these patients are very attached to their opioids. They're very, in many cases, unhealthily attached to their opioids. And so it can be a tough sell. And, my motivational interviewing skills are, honed over many years. And I use them in every encounter. And I've had a lot of success in convincing patients to do this change. The other another barrier to entry is this opioid use disorder baggage. Patients come in and either they know somebody using Suboxone for addiction, or they look it up and do some research and come back and say, hey, that's an addiction drug. Are you calling me an addict? You're labeling me. And, that's another conversation that takes time, and you have to have the inclination and the desire to sit there and, go over these things with people and say, no, absolutely not. I am using this this medication for your chronic pain. I do not think you're an addict. And, I reassure them, I tell them, I educate them about how effective this drug is for pain. And that's why they're coming to see me. I do have patients who come to me and say, I'm an addict, I need help with my addiction. But the vast, vast majority of my practice are pain patients who come to me and say, I need help with my pain. They're not telling me I have an unhealthy attachment to my medications. They're not saying, I'm more afraid of withdrawal than I am of pain. They're identifying their problem as pain. And so I meet them right where they're at. And I say, we're going to treat your pain. I'm doing this for your pain. Induction can be a little tricky. There's no CDC conversion factor, and I've found it to be quite variable. Some patients on 6 Norco-10s a day need 4 milligrams of Suboxone a day, and some patients need 12 milligrams a day or more. And I've found it difficult to predict. And so, over time, I've gotten better with the induction. I did have a patient last night who was on a fentanyl 75 patch, and I got a call last night at like 10 o'clock, and he waited, did everything I told him to do perfectly, waited 24 hours from after he took the patch off, and he did his COWS score, his clinical opioid withdrawal scale score was well above the level where I told him to initiate the buprenorphine, and he started it, and he precipitated withdrawal. He went into precipitated withdrawal and scared the heck out of me, and we spent a lot of time on the phone, and he didn't want to go to the ER, and so he got through the night and, used a lot of gabapentin. And today he woke up and he was feeling great. And his pain was a 1, and he was just flabbergasted. He'd only taken 6 milligrams. So even with all my experience, induction can sometimes be tricky. You need to know how to do it. And it takes it takes time out of my visit to explain to people, what they need to know in order to safely and, effectively have the greatest, success in their induction. But the rewards are, it's so worth it. I'd gladly spend an extra 10 minutes with a patient because I know, this is going to be such a huge success for them. It's also a little bit trickier around perioperative and inpatient use. When these patients go to the hospital for whatever reason or for a surgery, the surgeons aren't familiar with this drug. The hospitalists aren't familiar with this drug. And so they tend to get a little scared. And even though I've had multiple patients now go through their entire perioperative period, including, things like hip replacement on Suboxone, very successfully. They were very comfortable throughout the experience. A lot of times I still convert them back to a conventional opioid for their perioperative period, just to make it easier for the surgeons and for the hospitalists. So we'll take them, we'll put them back on something like oxycodone for, the perioperative period. The surgeon will send them home with their usual, whatever they require to manage their pain. And then they'll come see me a week or two later, and we will, as fast as possible, switch them back to the buprenorphine. And I'll tell you something, they're all super anxious to get back on buprenorphine. They don't want to go back to what they were doing. Convincing them to go on buprenorphine is a real challenge in most cases. They're very afraid to make a change, and it requires a lot of patient motivational interviewing to get them to switch. Sometimes it takes me years to get a patient to accept this. But once they do it, they all say, why didn't I do this 10 years ago? I would never go back. So they come back to me and they're like, get me off this stuff, put me back on Suboxone. And finally, if you're going to use Suboxone, the one of the drugs indicated for opioid use disorder, you really need this DEA X license or Data 2000 waiver. And that's gotten a lot easier now to get. You don't have to take all the courses anymore. As far as I understand, the latest, it's been switching around a little bit since Biden got in, but I think the latest is that you just have to apply for the X license. You don't have to take any courses. So we're all doctors. We've jumped through a ton of hoops in our lives. This is another little hoop you might have to jump through if you want to use Suboxone for your pain patients, and it's worth it. You'll love it. That's it for my talk. Thank you very much. This is my information. My cell phone is on there. My personal email is there. If you want to take a screenshot or write it down for down the line, if you have any questions, please go ahead and do that. I'm going to try to go into the chat room and see what I can see, if there are any questions. Before I do, as I'm trying to find it, there it is. But before I do, I want to recommend and encourage everybody to, tell all your friends about CalSIPP. We have some more exciting and, informative webinars coming up this year. We have our annual meeting. We're going to be back in person in Palos Verdes at the Terranea this year in October. It's going to be great to be back together again. And, we just want to get every pain physician in California and, around the world a member of CalSIPP and, taking advantage of all the great things that CalSIPP has to offer. So I see that there's a question here. How long should a patient be off methadone to start buprenorphine? And that is a great question. It's the $64 million question because I don't know. And when patients come to me on methadone, I usually recommend that they go do an inpatient detox. And I say, once you are safely converted from methadone to buprenorphine on an inpatient basis, come see me and I'll take over your outpatient prescribing. Methadone is so unpredictable in terms of its half-life, kind of like that fentanyl patch on the guy I did yesterday. Even though fentanyl in the OR, when we inject it, is very fast on off, when you use it as a patch over time, it accumulates in your fat and in your skin, and then it becomes like a slow release drug, kind of like methadone. And so it's very difficult to predict when somebody's ready to start buprenorphine after they've been on methadone. I offer them several options, and depending on what dose of methadone they're on, if it's not too high, I will, convert them to something like morphine or, for a month, and I'll just try to come up with an equi-analgesic dose of morphine to their methadone dose and let that methadone wash out for a month, and then I'll induce them a month later. They have to really be down low on their methadone for that, because I'm not going to prescribe somebody 1,000 milligrams of morphine. I'm just not going to do that. Everybody else is free to do whatever they want. The other option, like I said, is to offer them to go do an inpatient induction and then see you for ongoing maintenance. I have another question here. Do you use Suboxone for your low-risk chronic pain patients or the buprenorphine tablet? And I think you're asking, do I use, Suboxone with naloxone in it versus just plain buprenorphine? And if that's the question, if it's not, please let me know in the chat room. But if that is the question, then I'll let you know that I use Suboxone on everybody. I have maybe one or two exceptions where people have, they're convinced that they're allergic to naloxone or that the Suboxone product doesn't work as well. It's ridiculous. When you take Suboxone sublingually, you really absorb almost none of the naloxone. It's certainly not enough to have clinical significance. That's another myth and misconception that perhaps I should have addressed in the misconception section of this talk. The naloxone is there to deter intravenous abuse for addiction patients who are, heroin addicts injecting, opioids. The naloxone is there to prevent them from injecting the Suboxone. So the reason I use Suboxone on everybody is just for my license, just to be able to show that I'm doing everything in my power to keep these patients safe, to reduce the street market value of this drug, to reduce the risk reduction, to reduce the chances that they'll misuse this drug. And so I use Suboxone across the board on everybody. I don't use the buprenorphine tablet, but with rare exceptions. I do use buprenorphine patches. I do use Belbuca. They work better in the lower dose patients. So I have, chronic pain, low risk chronic pain patients who are doing great on their, 3 or 4 Norco 5 325s a day. And, I don't have any compelling reason to change the regimen, but sometimes I will just ask them, do you want to try something different? If your pain's around the clock, why don't we put a Butrans patch on? You only have to change it once a week. And some of them, do that and love it. So, yeah, the pure buprenorphine patch and the Belbuca, which is pure buprenorphine, work much better for those low dose patients who, if you give them Suboxone, even if they take a quarter strip of the 2 milligram Suboxone, oftentimes it's just overwhelming. They get too many side effects. It's too high dose. I have another question here that says fentanyl really makes inductions more rocky in our opioid use disorder patients. And I agree. It is a rockier induction because it does accumulate in the fat, it does accumulate in the skin. And so it starts acting more like methadone. It becomes more unpredictable when they should start. The guy that last night called me, his COWS score was 18, which is really high. A lot of people will start buprenorphine with a COWS score of 6 or 8. I tell my patients to wait until 12 or 15. And if I think they're sketchy and really, going to be, going to have a bigger trouble with the induction, I tell them 15 just to be safe. But if they look reliable and, I think I can trust them to do the right thing, I'll just tell them to wait till they're at 12. This guy was at 18 and he still went into precipitated withdrawal. So yes, Kyle, thank you for that. It's true. I discovered that last night. I have another question here. How would a 40 milligram oxycodone daily conversion to buprenorphine induction look for you? So that is kind of a standard induction. That's what I see probably most commonly, about 40 milligrams of oxycodone. That's, depending on what conversion table you're using, that's about 60 to 70 milligrams of morphine daily equivalent. And that's where I would say the majority of my patients come in. That's a pretty easy one. I would spend about 10 or 15 minutes explaining how this is going to work. I tell them all about the COWS questionnaire. I hand it to them. I show them how to use it. I, explain that I want them to stop their last oxycodone 12 hours before, the night before, and then wait 12 hours till the next morning. I explain that they're probably might have trouble sleeping that night. They might have a lot of pain. They might have a lot of withdrawal. Don't take any more oxycodone 12 hours later at the earliest. So at 8 a.m., if they took it at 8 p.m., you can take your first Suboxone strip, if I'm using Suboxone, and I tell them to cut it in half and start with a half or even a quarter sometimes. And I tell them to wait an hour, to not eat or drink, to keep it under their tongue, try not to swallow any. If they swallow, it'll go right through them. I ask them to keep it in their mouth, as long as they can without swallowing and without eating or drinking. And, I let them know that it's going to get easier down the line. But at the beginning, I really want to make a point of doing this with a very strict protocol because I want to make sure they're absorbing it properly. If they swallow it, they might think that this drug doesn't work for them, when in reality, they just didn't use it properly. So I tell them all this. I tell them that every hour they can take another half strip until their pain and or withdrawals are well controlled. And so they might do a half. As soon as they get to the point where they're controlled, I say, then you just stop and you wait. And if later on in the day, 6 to 8 hours later, you start to feel like the pain or withdrawals are coming back, you take another, whatever that dose was. So if it was a full dose, take a full one. If it was a half dose, take a half one. And, it's worked really well for me. Some patients get it right away and love this drug from the very first dose. A lot of patients require a few days, even up to a week or two, to really find their zone. And they require a lot of encouragement. I usually see these patients back in a week unless their HMO won't let me, but then I'll see them in 2 weeks. But I give them, a lot of times I'll give them my cell phone number, like the guy last night. And I knew he was going to probably have a difficult induction. So I just gave him my cell phone and I'll talk to him over the phone. And I can even now, because of telehealth, we can bill that as a 99213 or 4. And, I really, I want to be there and help them through that initial process. I don't get a lot of calls. I really don't. I rarely get a call. Patients just come back and they figure it out on their own. I see that that question about methadone was 40 milligrams per day. And as far as I am concerned, in my little cheat sheet that I use, methadone 40 a day is, somewhere in the, 300 to 500 milligrams of morphine a day. I would probably, ask that patient to consider either tapering down to less than 30 if they can for a month. And then I could convert them over to, something like morphine. at a much lower dose, or just recommend that they do an inpatient detox. And so then I got from the other question was about the low-risk patients. Andrea responded that, yes, that was the correct question. I have another question here that says, if historically, say years ago, patient failed buprenorphine due to side effects, would you entertain retrial? And the answer is yes, absolutely. Patients all the time come in and say that they've failed buprenorphine in the past. And I say, perhaps it wasn't done right. Perhaps, you didn't find the right dose. It means very little to me that they failed buprenorphine trial in the past. I say, you haven't done it with me, and I'm going to do it with you. And I really, think we can have success. I have another question here saying, what is low dose opioid? Well, I think that that's a very subjective answer, but we have the CDC saying that above 50 morphine milliequivalents is moderate dose, and above 90 morphine milliequivalents is high dose. So I guess, according, the consensus agreement in the United States is that less than 50 morphine milliequivalents would be considered low dose. I hope that answers your question. I have another question that says, I have encountered patients who are taking Norco and Belbuca. Does that make any sense? And, it doesn't make a lot of sense to me. I think it might be something that, could work for some people. I think it's really kind of doing them a disservice. I've heard of this over the years. I've heard of a lot of people, using Norco on top of Suboxone. I think it's a mistake. I don't do that. My patients do fine with just the buprenorphine. I think that a lot of this is psychological. These patients have this unhealthy psychological attachment to their opioids, and it's getting in the way of them achieving their goals, their pain management goals, and their other functional goals in life. And just putting them back on, a short-acting opioid like Norco while they're on Suboxone, it just reinforces that myth, that falsehood that I'm trying to lead them away from. I'm trying to lead them to a healthier, pain management decision. And so I think it's a mistake, Francis. I might do it under, duress if someone really, really, fought for it and made a good case, and I really couldn't lead them in another direction. But I bet your bottom dollar, every visit I would be trying to lead them away from that, gently, if they're compliant. And if they're non-compliant, then no way I'm going to do that. I have another question here that says, do you have any insurance coverage issues with chronic Butrans and Belbuca prescriptions? I find it is easier to get coverage for Subutex or Suboxone. Is that your experience too? I think it is. I use a lot more Suboxone than anything else. I do use a lot of Butrans, and I do use a lot of Belbuca. And I think that when I'm considering Butrans or Belbuca, I always am more concerned about the cost for the patient. But, it hasn't been a big obstacle in my practice. And so I find that when patients realize all the benefits of being on buprenorphine, they're willing to pay for it, and usually it's doable. If I put them on Butrans or Belbuca and it's cost prohibitive, I will switch them to the Suboxone and just try to use, try to get them on a quarter strip or something if they're on a very low dose of opioid. That answers that, I hope. Let me know if any of these answers are inadequate. I have another question here that says, what is the longest time one of your patients is on buprenorphine? Do you use any pure mu drugs other than perioperatively? I'm not sure I understand the second part of that question, but I've had patients on buprenorphine for over 10 years. There's a lot of debate. Should we be getting patients off of buprenorphine? Should we be leaving them on buprenorphine? I'm talking about in the addiction literature. And, some people in the addiction side hate buprenorphine. They think everybody should just be, substance free, and they call that sobriety. But, I think sobriety is, having meaningful relationships and a functional life, and buprenorphine provides that. And, I consider it a bridge to sobriety. A lot of patients will, stop the bleeding with buprenorphine, get off the street drugs, get back to a functional state where they can think straight, and they can get a job, and they can get back engaged with their families, and they can get their teeth fixed and their tires fixed and get insurance and, get their lives back together. And then later on, when they're stable and they have a support system in place, we can help them taper the buprenorphine. And it's a lot easier to taper buprenorphine than it is other drugs. I'm not saying it's easier to get off. At some point, patients have to make that leap, and that's difficult no matter what opioid you're taking. But the tapering part oftentimes is easier because they don't have that opioid-induced hyperalgesia. Do you use any pure mu drugs other than perioperatively? Linda, could you clarify the second half of that question? I'm going to move on to the next question until you give me clarification. It says here, how would you convert patients on a long-acting opioid like Xtampza and IR Oxy-10? And, you know, I don't use any long-acting oxycodone, but I would probably try to convert all of their oxycodone to a short-acting, you know, for a few weeks, a week or two. So I would take that Xtampza 18 Q12 and turn that into 40 of Oxy IR. So they were on 40 of Oxy IR. I'd probably give them Oxy 20 QID and tell them to take 1/2 to 1 every 3 to 4, 3 to 6 hours, and get them through a week or two, get that Xtampza long acting off of. Just a week is fine. And then, even a few days would be fine. And then convert them to the Suboxone. It's just, I think it's going to save you from a lot of trouble. But you could, say, look, take your last Xtampza 24 hours prior, take your last Xtampza, for example. I never like people to start their buprenorphine in the evening like that guy did last night. I prefer that they start it in the morning. So I would say, take your last Xtampza the morning before induction. Take your short-acting oxycodone throughout the day. Stop it, 12 hours before your buprenorphine induction. So that's another way to do it. Just have them stop the Xtampza 24 hours prior and then stop the Oxy IR 12 hours prior. And you can do the induction the same way. Just 12 hours later, do the CALS questionnaire if you want. I don't always use that, but if there's any question, you can. The CALS questionnaire is nice also because a lot of times when patients are struggling in those first few days and they call you and they say, well, I'm nauseous or I'm sleepy or I have low energy. I go, those could be side effects of either taking too much when you think about it, or they could be side effects of not taking enough. And I'm always kind of baffled. Should I tell this guy to take more or should I tell him to take less? And so having the CALS questionnaire there helps me a lot. I say, score yourself. And if they score really low on the CALS, it means they're probably taking too much. And if their score is high on the CALS, it helps me to go, oh, I think you're not taking enough and you should probably increase the dose. So I hope I answered that question about long-acting opioids. I think the easiest way is to just stop the long-acting 24 hours prior and use short-acting. And I tell them, I warn everybody, you're going to have a horrible night. I'd rather overpromise, underpromise, and overdeliver. So I just let them know you're going to have a horrible night. Probably, you just have to get through it. It's going to be worth it. And they're like, oh, they're scared to death of this process. Every single patient you meet, guaranteed, is going to be scared to death. Don't expect anybody to embrace this like with a big smile. They're going to look very fearful, and you just have to encourage them and help them through. It says, have you tried microdose inductions to cross-taper opioids? I have not. It's a great idea. I think I'm waiting to see, a little bit more literature about that. I've read a lot about it, and it looks really interesting, and it might be the way we do things in the future. It might turn out to be the better way. I haven't done it. And microdose inductions are where you leave the patient on their conventional opioid. So let's say they're taking 40 of hydrocodone a day. You just leave them on that, and you start giving them micro doses. And we're talking like 0.5 milligrams of buprenorphine. It really should be 0.2. That protocol was developed in Europe where they have lower doses of Suboxone available. In the United States, the lowest dose we have is the 2-1 dosage. So they would have to quarter their 2 milligram strip and then take that like twice a day for 4 days. And then you start taking a milligram twice a day for 4 days. And then you start taking, 1.5 milligrams and then 2. I don't know the exact dosing schedule, but you gradually bring up the buprenorphine over the course of a few days or weeks. And then you taper off the Norco, and it's supposedly a very smooth transition. Patients don't even notice any withdrawals at all, or very little withdrawals. So it's a great question. I don't do that yet. I have another question here. After induction, Are your patients typically taking Suboxone Q24, Q12 for chronic pain? These are really great questions. I mean, I find, and I've read in the literature, that when you're using buprenorphine, Suboxone in this case, for chronic pain, more frequent dosing works better. And in my experience, that's true. So, if you're using Suboxone for a patient who has heroin addiction or fentanyl addiction, you might do once a day dosing and just give them 8 or 16 or 24 milligrams a day. And, it gets their mind off the drugs. It gets them away from that idea that they're taking something. But with a pain patient, I will usually give them up to 3 or 4 doses a day. And I would say most are dosing about 2 to 3 times a day. I have rare patients who dose once a day. I have a patient who uses a half of a 2 milligram strip every 36 hours, and she loves it. She's perfectly happy. So it just depends. But most of my pain patients using Suboxone for pain are dosing 2 to 4 times a day. Okay. And it works better that way. Even though this is a drug with a 36 to 72 hour half-life, it can really, the effects for addiction and for avoiding withdrawals are very long acting. So I've had patients stop Suboxone and really have no symptoms for a week. I've had that happen because it's such a long acting drug. But the pain relief, kind of like with methadone, is, isn't as long acting. It's usually like 6 to 8 hours in my experience. There's another question here. Do you start any pain patients on pure mu agonist as part of a comprehensive pain program? Do you avoid pure mu agonist for chronic pain patients? And the answer to that is, I very rarely start a patient on a pure mu agonist. I mean, very rarely. Maybe once a year or less. I mean, I just don't do it. They come to me on pure mu agonists, and I, take over their pure mu agonists. And if they're doing well, I'll keep them on pure mu agonists. And by doing well, I don't mean they just don't have aberrant behaviors. I mean, their work badge is on, they're smiling, they're telling me their pain is well controlled, their pain scores are low. The wife comes in and gives me the thumbs up, great treatment plan. They're working and they're functioning and they're happy. But when I see that strung out looking, tired looking, compliant patient who just looks miserable, whose pain score is 12 out of 10, I got to do something. I'm not going to just leave them in that situation. So yeah, I avoid pure mu agonists for chronic pain patients as much as possible. And there's always that exception that confirms the rule. I know we all have patients who, I've had patients who are on high dose opiates who just abruptly stopped and didn't give a hoot, didn't seem to care at all. They didn't have much withdrawal, didn't miss the drug. I've got patients who take 30 milligrams of hydrocodone a day for the past 20 years, and they are the nicest, smilingest, happiest, well-controlled patients with lots of, great function. They're doing great in their life. I don't have any compelling reason to switch them off, but I do suggest it. I do often bring it up. Hey, you want to try something better? I do that anyway. What is the highest dose you use? That's another question, another great question. And I can tell you that in the past, I have used up to 32 milligrams of Suboxone. I don't do that anymore. I made that exception early on when I was learning how to use this drug for a patient who really was more of an addiction patient. And no matter how high I went on the dose, I couldn't get him to comply. And so I finally tapered him back down, and eventually he left the practice. I think that when patients are, let's look at the literature, right? I mean, when you're at 16 milligrams of buprenorphine a day, you've basically occupied almost every single mu receptor in your central nervous system. When you're at 24, you've got 99% of those receptors blocked. And remember, buprenorphine has higher affinity even than fentanyl. It's hard to bump that thing off. So you've got a tightly bound agonist on that mu receptor. There's no real point in going higher than 24. I think even 24 is an outlier dose for me. We do that for some patients, especially early on. They're still in that fear mode of their opioids, and so they still think, oh, more is better. And if I take more, it's more of a psychological thing than an actual physical thing. So I'll make the concession. I'll give them the 24, and then as they stabilize and start to realize how great things are going, I start talking to them about tapering to 20, 16, 12, 8. 8 is my favorite dose. I think 8 is enough for just about everybody. But I have a lot of patients on 12. I have a lot of patients on 16, and I have some patients on 24. Here's another question. Can you start buprenorphine on opioid-naive patients for chronic pain? And yes, you can. If you're using the Butrans patch, you can start them at 5 micrograms per hour. If you're using the Belbuca, you can start them at 75 micrograms twice a day. These are both drugs that you use for around-the-clock pain and generally are used after failure of conventional opioids, but they can be used in an opioid-naive patient. If that patient has around-the-clock pain, why not? I mean, perhaps we should be doing that. Here's the question that I have frequently in my mind, and it hasn't been asked yet, but perhaps some of you are thinking it. If you're using buprenorphine like I am, oftentimes a patient will be, taking 2 or 3 hydrocodone a day, or maybe they're using it sporadically, more sporadically than that. They're not using it daily. And I'm considering buprenorphine for them. And I really kind of question, I say, here they're being exposed to an opioid for several hours, twice a day or 3 times a day, or maybe every other day. And now I'm going to put them on something that exposes them around the clock to, their mu receptors to an opioid. Buprenorphine is an addictive substance, and it is habit forming. And just like anything else, you develop dependence. And so, I might hesitate to start an opioid naive patient unless I really thought this pain is never going to go away. The scenario would have to be right. And I'm very present with my patients. I'm just on a case-by-case basis. I don't have any cookie-cutter answers. And if I looked at that patient and I felt like, hey, this is going to be a long-term thing, this is around-the-clock pain that's not going away, and, I don't have other options, then I would consider using a patch on a naive patient. So, for example, I have older patients with like vertebral compression fractures with retropulsion, and, we're not going to do a kyphoplasty, and they don't want surgery, and they're just in horrible pain. And, all the other drugs aren't really doing it. The back brace isn't doing it. And they're kind of stuck there. We really don't have any other options. That's a guy that I would say, hey, let's put a buprenorphine patch on you, and I'll start him at 5, and I'll creep it up quickly. After every 3 days, you can increase that dose. There's another question here. Have you had good results with Subutex or Suboxone for advanced degenerative joint disease in patients who are not surgical candidates? I think those are great, just like I said about vertebral compression fracture, great patients to consider for Suboxone. Great idea. Yeah, if they have around-the-clock pain. I suppose even if they don't have around-the-clock pain, but if this is a very long-acting drug. Remember that. That's why I say when people have very episodic pain or they're just using a couple Norco here and there, I'm hesitant to put them on something like buprenorphine because it's so long-acting, and they're going to be exposed to it around the clock. It's a judgment call that, each one of us would have to make in our own practices. I've run out of questions here in the chat room. If anybody has any, last questions they want to pop up here, we'll wait a few more seconds. But I've just got a thank you for the talk. So listen, I really want to thank you all. We've been here, an hour now, and it's been hopefully an informative talk for you. I really want every single one of you to start using buprenorphine in your practices. If you're truly patient-centered, you can't not do this. And I also want to really encourage you all to invite all your friends to join CalSIPP. Come to the annual meeting. It's going to be so great to be back together. Join us for our future webinars. We have lots of good stuff coming up, and we'll keep you all posted. Thank you very much, and hope to see you all soon.